are talking about the 7, but it's a general concept that you cannot report a neurovascular conflict as a radiologist first. You have to wait for your clinical picture, otherwise your neurosurgeon will be very angry. That being said, related to the facial nerve, we call about hemifacial spasms. What is that? It's a progressive involuntary muscle contraction, mostly around the eye, sometimes a click in the ear. It's quite rare, but the clinical picture is very, very specific. So if a neurosurgeon sends you a hemifacial spasm, you have to look for a neurovascular conflict until proven otherwise. So where does the compression happen? It's mostly in, we call it the root entry or root exit zone, depending on the function of the nerve. It's the central segment, the central portion of the myelin, and the transitional zone, so where the central portion of the myelin extends to the peripheral portion, and it's believed that the central myelin is weaker, so more susceptible to compression. More specifically, on the facial nerve, there's an other, so you have your central segment, and you have a little bit an attached segment. So that's where the facial nerve is still attached to the brainstem, and then you have your transitional zone, and it's believed that and that's also what I have from experience, that the compressions mostly occur in the attached segment or the transitional zone. This is a case. Patient with hemifacial spasms on the left since 3 months. So we see something on the left side here. This is below the level of compression, and you see that there is a big artery here. Look here on the MR angiography. So what do we see? I'll tell you, this is the facial nerve, and it's compressed by an dolichoectatic vertebral area artery and a hypertrophic pica on the posterior side. This patient got a microvascular decompression, and then you see something very big here, and this is called the patch, and it's just as that's why I put it in. This patient also had a compression of the lower, the 9 and the 10, but this was asymptomatic, so you cannot call this in your report. So this is the post-operative image, so pre-operative, post-operative, where you see the vertebral artery, you see the facial nerve here, and this is the patch, so the nerve and the vessels are separated. So this is the idea of the surgery. Another case, this is the facial nerve with the conflicting vessel. Just for comparison, this is the vestibulocochlear nerve, this is the artery, and this is the facial nerve. So look how atrophic it has become. This is the normal left side, the pathological right side, facial nerve right, very atrophic, the facial nerve on the normal left side. And this patient was also treated with a patch, but if there's already atrophy, the results are not always that good. Personally, I don't do it, but in the literature you can grade your contact or conflict. I just keep it descriptive, but I know some people do it. So no contact is grade 0, simple contact is grade 1, a flattened nerve is grade 2, and a deformed nerve is grade 3, and this goes as well, of course, for the 5th cranial nerve, as well as the 7th cranial nerve. How do you report it? What's most important for the surgeon? And we will come back to that in the workshop. First of all, you describe your vessel, where you have an artery and a vein, and you describe the angle between the nerve and the vessel. So if you have cross compression, parallel, and then the cranial nerve, the distance of the compression to the brainstem in the entry zone, the location up, left, right, down, and whether there's deviation and atrophy. And these reports are quite short if you want to, but this is everything the surgeon needs to know. Perineural tumor spread, I will go very quick because I know Professor Kasselman has already touched upon this, and this is also his topic. What I want to emphasize, and that's why I took some time to maybe reiterate the anatomy, but you have to know your anatomy. Perineural tumor spread is most common on the 5, but also on the 7, and it's also very important that you report because it has for the prognosis and the treatment. Most common tumors: squamous cell carcinoma, melanoma, parotid lesions, and lymphoma. And in the seventh, the mastoid segment and the greater superficial petrosal nerve are most common, and the most sensitive sign is enhancement and thickening of the nerves. So this is still a case from Professor Kastelman. We gave a workshop together once, so we exchanged our cases. This is a lesion in the parotid gland, went up for the 7 and made the whole loop. This is a case from me from a lymphoma, and I like this case very much. If you have already too much now, I suggest you close your eyes, because we will make a whole tour of the anatomy, and no worries, I will go very quickly, but we retake this case in the workshops, because I think it's quite interesting. So if you're already over too much input, just close your eyes. So this was a cranial nerve, a tumor in the pterygopalatine fossa. From the pterygopalatine fossa, the tumor went in front in the 5-2, in the infraorbital nerve. It went back in the trigeminal cistern, the cavernous sinus, and now I always have to look at myself. Yes, then it went back again in the main root of the 5. From the 5, the main root and the trigeminal cistern, it went up in the orbit, in the ophthalmic nerve. This is again the greater, then from the big chunk in the pterygopalatine fossa, it went back in the greater superficial petrosal nerve. This is here, here, and here. From the greater superficial petrosal nerve, it goes back to the geniculate ganglion, so it reaches the geniculate ganglion, and from there it goes into the complete 7 until the parotid, and look here, also the 7 in the internal auditory canal. So this is a delight for your anatomy. I'm a professor of neuroanatomy, so I like these cases, but I can imagine maybe it's a little bit too much. And from there, this is the last one, and from the trigeminal cistern, it also took in the 5-3. So this is the anatomical overview, but no worries, we will go through that in the workshops again. And this one I liked very much when I started studying the connection between the 5 and the 7. This is a very technical or schematic overview, but I think it's quite helpful, and it's in your slides, so you can use it. Okay, we go to maybe lighter, or at least lighter from the point of view of the imaging, the inflammation. Inflammation of the 7 can be idiopathic, then we call it Bell's palsy, can be in part of infection, like herpes simplex or varicella zoster with Ramsay-Hunt, versus inflammation, sarcoidosis, and Guillain-Barré. Patient present with a unilateral complete facial nerve palsy, and on MRI we see abnormal nerve enhancement. Of course, you have to have the labyrinthine segment to be sure the enhancement is pathological, and sometimes you can see an edematous nerve. And to be honest, from the part of imaging, that's it. Because we are not able to differentiate between, for example, a Ramsay-Hunt with the 7, the 8, and the inner ear, or a Guillain-Barré syndrome, which is post-infectious autoimmune acute inflammatory demyelination. Often the only thing that can help you is that Guillain-Barré is often bilateral. So the thing is, you will need to describe it, and sometimes you have the other findings, like this was a Guillain-Barré bilateral. It's quite typical, so neurologists know if you have a bilateral 7, it's most likely Guillain-Barré. And in this case, we also had the typical imaging findings in the coda equina. And then this was a case where there was a long doubt between sarcoidosis or neuroborreliosis, but at least looked also a little bit greater superficial, also the other cranial nerves. But in fact, as a radiologist, you cannot make the difference, so you only have to describe it. Tumors, also very short, primary neurogenic tumors of the facial nerve, as you can see here, are rare. Mostly they are in part of the neurofibromatosis complex, and sometimes you have the compression by the 8, the tumors of the 8, the vestibular schwannomas, and you cannot really make the difference. And what do we see are well-defined, enhancing fusiform masses. Secondary tumors like metastasis, lymphoma, meningioma will most of the time give you, will be provided in the context. And remember, especially with metastasis, the clinical features are often mild. I mean, you have a sick patient, but the cranial nerve palsies will be incomplete. And then we come to the end, trauma. Of course, the clinical picture or the context is clear. What are the weakest points? The geniculate ganglion and the tympanic segment is most often involved. You need your high-resolution CT, and sometimes you have to do repeat imaging because if the context is so heavy, the facial paralysis will not always be clear. And when the patient gets off, for example, the ICU, they say, "Oh, we have a palsy of the 7. Okay, you maybe need to do repeat imaging." There are different classifications. The older one are the transverse versus the longitudinal fracture, but the most recent one, and I think it's also more helpful, is whether the otic capsule is involved. And when you have involvement of your otic capsule in trauma, you have more likely have a facial nerve paralysis. So here, and again, it can be quite subtle, but look for it. Hemangioma, typical lesion, you will certainly see it a few times in your career. These are benign lesions of the temporal bone in the region of the geniculate ganglion. Patients have an adult presentation, so no kids, and it's a more slower of progressive facial nerve paralysis. And CT, you see the honeycomb change in the bone, and on MRI, you have what we know from hemangioma, so a little bit enhancement. Sometimes you see the flow voids, but it's not enhancing as much as, for example, infection or inflammation. And then finally, a nice one to end, the congenital one, the Möbius sequence. What's that? That's a spectrum of congenital malformation, mainly affecting the cranial nerves, and this is due to ischemic changes during fetal development. Patients present with different symptoms, but what all these patients have is one uni or bilateral facial nerve palsy, and this is why, again, I emphasize the anatomy. What you see is if the nuclei are ischemic, you don't have there are no cranial nerves in this cerebellopontine angle. That means you also don't have the facial colliculus. So what you see is a flattening of the floor of the fourth ventricle, and here you see 3 cases from the literature. So that was it. Just apex and facial nerve imaging, anatomy and imaging are key. The anatomy is quite complex, and often, you know, the clinical picture is often aspecific. You know, headache, tinnitus, some facial nerve palsies, but you have a very important role, let's say, and that's why the anatomy for sure is very important. We talked about a broad range of pathology, which we will deepen in the workshop, and you need a systematic approach and logical thinking. That's the only way I could emphasize, or I could summarize the complex pathology in one slide. So thank you very much for your attention, and I hope to see you in the workshop.